The consideration of chronic rheumatic valve disease really has to begin with just a few words about acute rheumatic fever. That, as I'm sure most of you know, in acute rheumatic fever, the patient, usually a child, develops a streptococcal sore throat. There is a latent period of perhaps 2 to 2.5 weeks, and then the child develops acute rheumatic fever. This is really a clinical condition with fever, flitting arthritis, transient skin rashes, and what is particularly important in relation to chronic rheumatic valve disease, a proportion of the patients get a pancarditis. The term pancarditis means that there is pericarditis, myocarditis, and a valvulitis. Now, I think it's difficult to know what proportion of children who get acute rheumatic fever get a carditis. It is certainly not 100%. We could take a guess that it is perhaps 5%. What we need to realize is that there's a latent period between the acute infection in the throat with the streptococcus and the development of the acute rheumatic fever. So that is the first latent period. I'll come in a moment to talk about the next latent period, but let's first just stick with acute rheumatic fever. The pericarditis is unimportant. Unimportant in the sense that it does not lead to any long-term sequelae. It is important in the sense that it produces a pericardial rub that can be heard clinically, but it's really not important in relation to the later disease. The myocarditis is important in the sense that it is responsible for the acute phase mortality. Now, we in this country have reached a stage where rheumatic fever is rare, and if it does occur, it's mild. This is not true of all parts of the world where disease is still rampant. And in places where the disease is rampant, there is still a mortality, and the mortality really relates to left ventricular failure as a result of the myocarditis. The third element is the valvulitis. The valvulitis, again, is not important clinically during the acute phase, but it is important in relation to when we come to talk about chronic rheumatic valve disease. If I could, though, just show you something of these elements. The first thing to say is there is acute rheumatic valvulitis. It is characterized, and we're looking at the mitral valve, it's characterized by the deposition along the apposition line of the cusps of small, flat, rather brownish thrombi. And these are very symmetric. They go all the way along the closure line, particularly of the mitral valve, sometimes of the aortic. They are not large vegetations, they don't grow out like mushrooms, they do not embolize, and they ultimately resolve and are incorporated into the cusp. But that is what the acute phase valvulitis looks like. Histologically, if you look underneath these vegetations, there are varying degrees of inflammation of the valve, there are varying degrees of fibrinoid necrosis of the connective tissue. But I would come back to the point that in the acute phase, the least of the patient's worry is the valvulitis. The myocarditis is interesting because it has got a very characteristic histological picture. Really, you get the formation of tiny granulomas, that is collections, focal collections of giant cells, actually in the connective tissue of the myocardium and of the subendocardium and sometimes the valves. These are little round foci, you can see this is an Aschoff body. It's microscopic, and I think one mustn't lose sight of the fact you do not see an Aschoff body at naked eye. These are microscopic structures. It usually has a little central focus of collagen that looks slightly different, and then round the outside we have got these cells. One Aschoff body looks very much like another, and here is another example of it. You can see we've got the connective tissue here and these inflammatory cells, giant cells, arranged around the outside. It is a very characteristic piece of histology. It doesn't occur in any other condition that I know of, and you cannot, I think, reproduce it in any animal models. So it's a highly characteristic piece of pathology, and what it's telling you is that the patient has got acute rheumatic myocarditis. But as I've said, as long as the patient hasn't got such a severe degree that they die, by and large the myocardium ceases to be a long-term problem. And these Aschoff bodies resolve over a period of many years. They are long-lived granulomas. They do not go away at once, they simply persist and slowly become small connective tissue scars. Just pathologists are, as many of you know, very obsessed with naming things and descriptions, and I'm just using this slide to give you some of the names that are applied to the cells that are in the Aschoff body. This cell here, you can see it's got a long bar of chromatin down the center of the nucleus. This is the so-called Anichkow myocyte. A poor name, because I think it is not a myocyte at all. This is a histiocytic cell of some sort. That is the Anichkow myocyte. These small giant cells, these are the Aschoff, so giant cells, described originally obviously by Aschoff. So the histology then is characteristic. I think all of these cells are probably of histiocytic origin, although there used to be an idea that they may be altered cardiac muscle. I would think that view has now gone. So we have a particular histological pattern that would tell us about rheumatic myocarditis. I think there's one thing to remember about the Aschoff body. This simply plots the experience at St George's. St George's was into valve surgery for rheumatic disease really quite early. So in St George's, stowed away, there are atrial appendages taken out at mitral valvotomy over many years. And it's quite interesting that if we look here, we're first of all plotting, this is the age of the patient at surgery. This is the frequency of finding Aschoff bodies in the atrial appendage removed at mitral valvotomy. And the figures don't matter, but I think what they show you is that in this country, the age at which the patient is operated on is rising steadily, and the frequency of finding Aschoff bodies has fallen. And this simply reflects that the persistence of the Aschoff body is a measure of the time that has elapsed. That as years go by, you get a lower and lower frequency of Aschoff bodies. But it does tell you one thing, and that is that the Aschoff body is not a marker of rheumatic activity in any way. The report of Aschoff bodies in the atrial appendage means nothing more than the patient has had in the past rheumatic fever. So I think that judging rheumatic activity is quite difficult. That's really what I wanted to say about acute rheumatic fever, except next to emphasize that the patient who's had rheumatic fever and has had carditis and gets better, there is then a second latent period. And after that second latent period, we get what we would refer to as chronic rheumatic valve disease. The latent period varies very considerably from, I think, geographic area to geographic area. In the United Kingdom, where acute rheumatic fever is now virtually gone, one sees very long latent periods. One is seeing patients present with chronic valve disease 25, 30 years after their acute rheumatic fever. That is not true of the disease in, for example, India. In the continent of India, you may see acute rheumatic fever at 10, 12. You may see mitral stenosis 2 years later. So where the disease is still rampant and virulent, that second latent period is much shorter. I think we have to at this point ask ourselves, well then what is the pathology of the valve in chronic rheumatic valve disease? And there are really two hallmarks of the disease. One is commissural fusion, and the other is cusp fibrosis. Commissural fusion obviously narrows a valve orifice and will produce stenosis. Cusp fibrosis tends to shrink and retract the cusps, so it leads to regurgitation. And really what is very striking about chronic rheumatic valve disease is that you get all combinations of commissural fusion, cusp fibrosis and retraction in any combination of aortic, mitral and sometimes tricuspid valve. So you get mixtures. You get a mixture of stenosis and regurgitation in more than one valve. And that is what clinically is so highly characteristic of chronic rheumatic valve disease. Now what I want to do now is to move to show you some specimens, and I think one has to say that there's a terrible monotony about chronic rheumatic valve disease. We have only got a small number of permutations. Commissural fusion, cusp fibrosis, we've got those as variables. Which valve is affected? So don't expect to see a wide range of pathology. But let's look at some of the sort of things that we see. And I'm going to start with mitral valve stenosis. Perhaps I would do better to start here, which is a normal mitral valve. And I just want to make one point about this normal mitral valve. The end of my index finger is something like 1.5 square centimeters, because I happen to know that is so. This is a normal mitral valve, and you can see that this is the what I would call the anterior cusp. There's the posterior cusp, and the commissure is beautifully free. These cusps are separated right up this point and here. And if I take my finger, I can very easily actually pass two fingers straight through that valve. So the normal mitral valve has a large area, open area, because the commissures are actually free and the cusps are mobile. Now, we could say, I think, much the same thing about the aortic valve. The aortic valve orifice, when open, is large because the cusps open out, separate from each other right up to the commissures. Now, how does that contrast with rheumatic valve disease? This is mitral stenosis, and we're looking here from the left atrium, and we're looking straight down onto this valve. The first thing to say is that the orifice, as you can see, is this sort of oval shape, and if I take my finger, I can actually get one finger through it. So this is a valve of about 1.5 to 2 square centimeters in size, orifice size. But you can see there has been commissural fusion here and here. And it's this commissural fusion which is reducing the size of the orifice. At this commissure, we've also got I don't know whether you can hear it, but we've got calcification. So the fibrosis here, excuse me, has undergone calcification, which is a fairly common age-related phenomenon. Now, this atrium is neither large nor very big, and all one can say is that this is some atrial enlargement and that there's no thrombus in this atrial appendage. And this is fairly typical mitral valve stenosis. The next thing we always do is to look at the other valves. Can we see any other sign of involvement of the other valve cusps? And the heart has been opened, and I think it signifies that the sheer fact that the valve has been opened, probably there wasn't aortic stenosis, but what you can see if we just look at that commissure where I've got the forceps, at this point we've got commissural fusion. So there was a degree of aortic valve involvement. So here we've got dominant mitral valve disease, dominant stenosis, some aortic involvement but probably subclinical. We've got a rather dilated right atrium, but here you can see that the valve is still mobile, there's a large orifice, so we've got really no sign that the tricuspid disease. If we turn the specimen over and look from underneath, we can get some idea of the pathophysiology in the sense that this is a very thick right ventricle. So this patient has had pulmonary hypertension, and pulmonary hypertension is a very striking part of mitral valve stenosis. So here we've got very typical heart. We've got mitral stenosis, we've got right ventricular hypertrophy telling us that there was pulmonary stenosis, there was pulmonary hypertension, and we've got trivial aortic valve disease. Now, if we take other examples, you'll begin to see what I mean by the monotony of chronic rheumatic disease. Left atrium, we're looking down on this mitral valve, the very characteristic oval opening. The commissure here is fused, commissure there was fused. But this time I cannot even get one finger through it. So this is really significant tight mitral stenosis, predominantly commissural fusion. That if we look at over here in the tricuspid valve, obviously no involvement there, huge orifice, these cusps are freely mobile. So we've got no tricuspid valve disease. That if we look at the aortic valve, we have got just there the suggestion that some commissural fusion just of one commissure. So this is a touch of aortic disease, but again not clinically significant. That the heart I've got here, there's been a surgical attempt in this heart to actually relieve stenosis at cusp level. And what has actually happened is that the surgeon has gone in and he has split this commissure. You can see at that point there. There's been a surgical split and an endeavour to relieve obstruction at valve level. That insofar as one can see, that very little was probably done this commissure here. The main surgical attempt was relieving this fusion at that point. Now, I want to show you this heart though to make one other point, and that is here you can see the left atrial appendage in this heart. There is a lot of antemortem thrombus. And some cases of mitral stenosis have thrombus in the atrial appendage, others don't. It's difficult often to see why thrombus is present or absent. The larger the atria, the more likely to be thrombus. The presence of atrial fibrillation is more likely to be thrombus. But it's a very variable, somewhat unpredictable thing, the presence of thrombus in that appendage. This heart shows one other feature, that now if we look at the tricuspid valve in this specimen, as we look down the valve, the cusps are obviously much more opaque, white and thick, and if you look at this commissure, we're getting some commissural fusion here in the tricuspid valve. So here we've got clear evidence of rheumatic involvement of this tricuspid valve, although the fusion does not go up into this commissure, and I can actually put one finger through, not quite two, but remember the orifice of the tricuspid valve normally is very much bigger than that of the mitral. A normal tricuspid valve should be the order 5 to 7 square centimetres. This one is probably about 3. So in this heart we've got a degree of tricuspid valve stenosis in association with mitral stenosis. If we look in this heart, and I think we'll need to sort of look straight down the barrel of the aorta if we can, if we look down on this aortic valve, what is striking is that these cusps are really rather fibrous and rigid. And I think that that shows it rather nicely, that although there's some movement in this cusp, it's very markedly thickened, although the commissure isn't fused. So we've certainly got some cusp fibrosis, although if one puts the cusps together, you probably make them oppose. But it's quite likely that in this case, this lack of cusp mobility gave a degree of aortic regurgitation. So in this heart, we've actually got evidence of mitral disease, tricuspid disease, and aortic disease altogether. Again, very characteristic of chronic rheumatic valve disease. There's one other thing I think that we should really stress about mitral stenosis. That here is a specimen, and I think if I can, I don't think I can get quite easily into it, but yes, there we are, that's better. We're looking down on the mitral valve, and it's obviously got quite a small orifice here. I want to make one point about it, is that there's a huge rock of calcium present at this lateral commissure. And although it is true that perhaps the most well-recognized and the well-known cause of stenosis is commissural fusion, that you do increasingly in our population, our aging population, see heavy calcification as an element of stenosis. So the valve calcifies, you get a very stiff, and that is another element of stenosis. There's yet a third element of stenosis, which this heart shows rather well. Blood, when it leaves the left atrium, passes in the left ventricle between the cusps, obviously, and it then has to sort of go out from between all of the chordae and the papillary muscles. We do see a situation in severe disease where the chordae become fused together into just a solid pillar of fibrous tissue. And you can see that here. These are recognizable chordae, but here, that is the cusp, there's the papillary muscle, and instead of chordae, we've just got a solid pillar of fibrous tissue. And what is happening here is that you have got an element of sub-valve obstruction. So that the obstruction here is at least partially below the level of cusps. Now, is that important? Well, I think it's important for the surgeon in the sense that if stenosis is purely commissural fusion, it may be repaired conservatively. You simply split the commissures. If stenosis is due to cusp fibrosis and to cusp calcification, you may have to replace the valve. If there's a big element of subvalve stenosis, I think you're into a much more difficult situation, and you're going to at least have to take out this subvalve apparatus when you replace the valve. But I wanted to show you this specimen to make the point about the subvalve element and caudal fusion as an expression of chronic rheumatic disease. Now, the messages that I've been giving you are equally applicable to surgically excised valves. There's one great knack about surgical excisions of valves, and that is really keep what the surgeon sends you intact, and if you can train your surgeon to take out valve in a reasonably single piece, you get much prettier specimens. Here, for example, is a valve taken out, and if you look at the valve from above, I think one can start to sort out what the pathogenesis of the disease is. If we count the number of cusps here, there are obviously 1, 2, 3. So this was a tricuspid aortic valve. There's clear commissural fusion from there to there, here to here, although this commissure is less fused. And there's heavy calcification. And one would look at this valve and say this is really rather typical of chronic rheumatic valve disease in this sort of aging population that we have in the United Kingdom. This is rheumatic because you've got fusion of the commissures, but probably there's an older person because we've got heavy superimposed calcification. You can contrast that to the valve here. It looks slightly different, but obviously there's a central orifice. Difficult to see how many cusps there actually are. But if we turn it over the other way, you can see that originally there were 1, 2, 3 cusps. So if we go back to this surface, what we've got is really a very marked degree of fusion, of rather symmetric fusion of all 3 commissures. And this is very typical of chronic rheumatic aortic disease. And what it gives you is it gives you a degree of stenosis because this is a reduced aperture, reduced because of the commissural fusion, but it also gives you a degree of aortic regurgitation because this cannot be closed by cusp movement in any way. So this is a very typical chronic rheumatic valve. This would be a mixture of aortic stenosis and aortic regurgitation, and very easy to recognize as long as you remember to look straight down on the valve from above. So those are the pictures that one gets in the aortic valve. What about excisions of the mitral valve? Well, again, if one keeps the valve intact, you can see here, there is the valve. If we simply put a finger through it, we can see that that's probably not significant stenosis, if you can put a finger through it so easily. But is it then a normal valve? And the answer is no, that if we look at it, and it would be easiest if I actually open it for you. If we look down on that valve, we can see that a tremendous amount of cusp fibrosis. I mean, that is the first point. The cusps are obviously rather small and shrunken. And we can see that if we look at this point here, the chordae are only that long, and they're all fused together. So the solid fibrous obliteration, if you like, incorporation of the chordae into a solid fibrous pillar. And I think you can well see that if your chordae are short and fibrous like that, what you're doing is you're simply tethering the valve cusps down onto the apex of the papillary muscle. And you can see there's the apex of the papillary muscle. So this is a very typical way in which rheumatic disease produces pure mitral regurgitation. The cusps are fibrotic and shrunken, but perhaps more important, they're actually pulled down and tethered towards the apex of the papillary muscles. So this we can't meet and oppose and close the mitral valve in ventricular systole. So those are the specimens that I brought to show you that I think there's this terrible, as I've said to you, monotony about chronic rheumatic valve disease. They all look the same. Your permutations are just in whether it is predominant commissural or caudal shortening, etc. I think we need to make some comments about what is going on in this second latent period. Describe that the patient has acute rheumatic fever, and then there is a latent period of often years. What is going on? Well, I think there are two schools of thought in relation to this. Both are probably true. It may well be that in this second latent period, the patient is actually going on having subacute further attacks of rheumatic fever. In other words, there is persistent acute rheumatic activity. Do we have evidence for that? Well, the only evidence we have is that it's well known that if you've had one attack of acute rheumatic fever, you are more susceptible to others. If you have more than one attack of acute rheumatic fever, your risk of developing long-term valve disease is far higher. We do know that if you've had one attack of acute rheumatic fever and you are followed sequentially by tests such as the anti-streptolysin O titer, that it's clear that you get sporadic rises in ASO titer, meaning that you're having a streptococcal infection, but you don't have symptoms. And I think perhaps most telling is the fact that if one goes to countries like India, parts of Africa, South America, where rheumatic disease is still rampant, the latent period is very short, suggesting that those indeed are patients who are having current attacks or even persistent activity and then getting chronic rheumatic valve disease. I think there's another way of looking at this second latent period. If we look in a country like the United Kingdom, the latent periods are long. And what we're tending to find in the United Kingdom now is that we're seeing really this sort of disease. Disease associated with heavy calcification. And what this may suggest is that what happens in acute rheumatic fever is that you're given a damaged valve. You end up with some valve damage. And then over the next 5, 10, 15, 20 years, hemodynamic effects of having an abnormal valve lead to what are purely secondary changes, leading to calcification.